شغال. صباح الخير. انا بتشرف طبعا بوجودي معاكم في المؤتمر، واتس بليجر ان دكتور احمد عثمان دكتور محمد فوزي دعوني ولجلسه التشست. طبعا دايما we're very happy ان احنا to share the knowledge، واحنا we're very proud دلوقتي ان احنا we're sharing a knowledge that has been going on for 2.5 years. احنا هنتكلم النهارده على innovations in lung cancer screening والاكسبيرينس بتاعتنا in Egypt together with دكتور خالد عبد العزيز الاكزيكتيف دايركتور بتاع الانيشيتيف نفسه كله. احنا هنتكلم، انا كهشام وهبه هتكلم radiological aspect what we've been doing يعني over the past 2 years and what is lung cancer screening, what are the experiences that has been going around in Egypt. So lung cancer screening, I remember 2 years ago I was standing here discussing 6-month experience since we started lung cancer screening, and now we're proudly presenting 2.5 years after starting this experience. Now we're covering all over Egypt, so we're talking about 27 governored. All of them are included into the lung cancer screening program. The mission and the vision. The mission of the initiative was mainly to reduce the incidence of cancer, aiming to reduce mortality and to reduce the extra cost that the government is bearing the consequences of treating cancer patients. And the mission is mainly to reduce the morbidity and mortality caused by cancer, specifically lung cancer, over the coming few years to reach a healthy Egyptian population. The pillars for diagnosis of lung cancer regarding the radiology aspect, and this is we've been talking through these topics several times before. The main pillars are low-dose CT, AI, and lung rads. So this is what we're doing as a radiologist in lung cancer screening campaign. If we talk about low-dose CT, it's basically a normal CT scan, 16 multi-slice CT scan with a low-dose protocol, reducing the radiation dose, and the main aim of low-dose CT is mainly to detect pulmonary nodules. So reducing the dose, reducing the hazards for the patients, and at the same time picking up the nodules easily. The dose can be automatically adjusted, or a preset protocol according to the vendor can be preset on the machines. And we have several machines scattered all over Egypt now, so we're covering all geographic areas where the campaign is happening. The indications for low-dose CT is mainly detect lung nodules. So we're not focusing on mainly lung pathologies and so on. The main focus was at the beginning only lung nodules, and I'll tell you later what we've been changing lately regarding the lung health in general. The primary goal of CT is to detect abnormalities and mainly lung nodules like we talked. And the challenge is to take the CT in one breath hold. So the challenge to do a protocol that is really adequate for picking up small nodules is to scan the patient from foot to head, like codocranial. It's better because the most movable part of the lung is the lung basis. The slice thickness, we're talking about less than 2.5 and mainly less than 1 millimeter is preferable to detect smaller nodules than smaller than 2 millimeters. The key for detection of small nodules is to do MIPing, maximum intensity projection images, to pick up smaller nodules in an easy way. طبعا the dose should be less than 3 milligray for each patient according to the patient size, and we don't use any contrast injection, neither oral or IV. What about AI? There are several vendors now happening and selling their products around the world. We did put hand in hand with a couple of them as a trial. All of them were very successful, and they were very accurate at detecting lung nodules, and we're using them as a helping tool. It's not the final call. The final call is for radiologists, but they are mainly for helping tool. The main aim for AI is detection of pulmonary nodules, characterization of this nodule, and segmentation of the nodule. What does the AI does? It has a comparable results compared to the radiologist, and even now studies say that AI together with radiologists get better results, especially with the overload that we're facing on daily basis. So together, AI and radiologists can get better results, and there are several studies that has been published regarding the efficiency of AI helping radiologists get better results, or even replacing radiologists at one time or another, which I'm really doubting now. These are examples regarding the statistics and the comparison between radiologists doing those studies and reading low-dose CT alone and reading with the help of AI, and the sensitivity increased significantly after using the AI. But there are some papers saying that still requires senior supervision and input. This is for sure a mandatory pathway. We don't depend only on AI, but I'm really afraid maybe in the future AI will take it over, so let's hope not. The nodules are easily picked up by AI. They usually pick up the nodules around the hidden areas and near the small vessels and so on. And the radiologist confirmed the presence of nodules and then annotate them in the report. And the report is focused on lung rads, so we're talking only about nodules and their level of lung rad criteria. Characterization, the AI has even very sensitive detection rate and characterization of the nodule itself, whether it is solid or it is ground glass or mixed solid and ground glass nodules. Like those nodules, the AI can pick them easily. And when we talk about ground glass opacity, it has to be seriously taken in consideration when we're doing lung cancer screening, because some of those ground glass nodules turns to be cancer later on. This is how AI characterizes the solid part and the ground glass part, and even measures each part separately and gets us some sort of volumetric analysis of the nodule itself. And this is another example how the AI can detect even the rate of characterization, whether it's most suspicious to be malignant or not, and giving a rate for that. The marginal nodule, even if it is speculated and so on, it can be mentioned by the AI, and even the features of the nodule itself. So it's a great tool to help us even focus more and more on what we're doing during reading lung CTs. Regarding the segmentation, the AI has done great work regarding localization of the nodules, and even giving a volumetric analysis, and even subtracting the nodule from the rest of the lung and getting it separately into a totally different view. And like we can see here, the AI can detect the volume in three-dimensional way. So accurately, you can do a follow-up through the same vendor of AI and gets you a clear comparison between the baseline and the follow-up after 1 year, for example, for a regular lung rad tube lesion. Another example of AI picking up the nodules and segmenting them, localizing them, and giving some sort of measurements. Another example where the AI can really subtract the nodule and give you a 3D model or appearance of the nodule standing out away from the study itself. The results have shown significant improvement regarding the confidence of radiologists getting the results accurately through the AI. So when we compare the radiologist alone, radiologist to AI, the level of confidence increased, not only detectability, but to be sure that this is a serious nodule, the AI helped the radiologist so much. Even in lung rads, when we document our reports, we read through lung rads. So sometimes lung rads are a little bit confusing. AI increased the rate of confidence getting better in lung rads. There are false positive results, of course. AI can pick up a lesion like this one and say this is a suspicious lesion regarding the borders and the appearance, but from the experienced radiologists now we can say this is most likely inflammatory and recommend follow-up. And this is what we do in our MDTs. So we have regular MDTs between pulmonologist, surgeon, and radiologist, and we discuss these kind of lesions, whether we should follow up on a closer time frame, or we should go for a further better analysis like PET-CT, for example, to pick up the abnormality and choose whether it is inflammatory or not. So this is a false positive result, and this is just an inflammatory lesion. The lung rads, we're following the lung rads criteria, the latest version, and lung rads is mainly focusing on regularizing the radiologist report under one big umbrella, so we talk the same language and it's not confusing. Lung rads have been successful because the ACR started the BioRads 20 years ago, and it made successful story. And now we have rads around all subspecialties, BioRads, for example, for prostate. And the lung rads are taking good lead in detecting and stating the pulmonary nodules. It started in 2014. Now it has been 11 years since the long rads have been created. And we're using in the campaign the latest version, which came to light in November 2022. And this is example of the long rad. Ironically speaking, last May, we discussed a new initiative through the pathway of lung cancer screening, and we said, now we're facing a lot of challenge attracting patients to come do lung cancer screening, because when you talk to a smoker, a healthy guy, he's running on his feet and everything is fine, and tell him, okay, come and we will detect lung nodules and maybe you have cancer. All patients run away. So this is a fact. Now we're changing the model a little bit and making a lung health rather than lung cancer campaign. And we introduced some sort of other findings regarding lung health. Example, chronic smoker have emphysemas, other changes in the lung. So we said, why we don't add on some more diagnostic tools regarding the lung rad CT or low-dose CT, and instead of detecting only nodules, stating the pathologies in the lung, so hitting both targets at the same time. So changing lung rad screening and naming it lung health will attract much more people to do lung cancer screening in the coming future. Through the lung cancer screening campaign, there were smoking cessation campaign, and here are the results. Around more than 600 smokers presented to the campaign, and maybe Dr. Khalid will elaborate more about the numbers. And these are the numbers have been enrolled and continued into the smoking cessation campaign. So we're talking about 54%, and this is a large number. It's very promising. So if we're talking that the campaign will continue, I think in the near future we can have a better awareness about smoking, and we'll have a smoking-free society. Those are the total numbers that have been enrolled since the beginning to do a low-dose CT. We're talking more than 92,000 citizens. But unfortunately, only 15,000 did the low-dose CT, and there are factors affecting this, whether the CT is near their location or whether they are afraid to do the low-dose CT after being enrolled into this campaign. And the results, we're talking about 16% only of the patient that has been enrolled to do the CT that did effectively the CT. The results have been lung rad 1, 2, and 3, 97%, which is good. And the lung rad 4, 3%. The final results that we got, pathological proven lung cancer over the past 2.5 years, 77 patients have been truly diagnosed with lung cancer. And this is a good number. Now we can say, okay, we can early detect, we can early treat, and definitely the patient have a better survival rate. Thank you so much.